So, can anyone in the room treat anything they can't define? Well, we do the best we can until we can define it. But it's very, very, very difficult to treat anything until you know what you're treating and why you're treating it. So let's take a look at the culture of the eye field. Let's take a look at what our teachers and what the past has brought us. In the year 2007, which is quite recent, the best definition of dry eye was it's a multifactorial disease of the tears and ocular surface that results in discomfort, etc., etc. And it's accompanied by osmolarity of the tear film and inflammation. Now, what I would propose to all of us is that those are sequelae. Those are the results of the cascade, and something causes it. And I would like to show you the evidence that it's desiccating stress caused by the meibomian glands. So what has all this done to us? It's focused us on water. It's focused us on the Schirmer test, which was, I believe, 1901. That doesn't mean we shouldn't do it. It just means that's where we're focused. And the current National Institute of Health definition in the United States is dry eye occurs when the eye does not produce tears properly, or when the tears are not of the correct consistency and evaporate too quickly. So the primary message is that we have inadequate tear production. There is not adequate tear production. And again, what happens? The focus is on water. So I could go on with more definitions, but they all say it's a condition where there are sequelae. So what are we doing? We are treating the symptoms. So if somebody comes in with red eye, what do we do for them? We hit them with steroids. We do something to get rid of the redness. And we're very lucky because today we have much better steroids for this purpose than 1% prednisolone. So I'm not saying that there isn't progress, but what I'm saying is essentially what we have done is we have focused on the wrong problem. Now, if we go back to 1980 and we look at our original article, we proposed 4 treatments. One was warm compresses, one was lid scrubs over the orifices, another was manual expression, and another was the use of drugs. But they all had limited efficacy. So if I were just to take a quick poll of the audience, how many in the room prescribe warm compresses for people? Okay. By almost 75 to 90%. How many of you specify a specific time? Okay. And how many of you prescribe a time of at least 8 minutes? Okay, so we have 2 or 3 who do that, okay? Well, as I will show you, it took me 28 years to do the definitive study which shows us what warm compresses do and how we should do them. 28 years. I sat there like a fool for 28 years, just giving people warm compresses and not instructing them properly and not having the correct data and not understanding it myself. So what happens? If you put a warm compress on at 45 degrees centigrade Celsius, which is 113 degrees Fahrenheit, that's about the highest temperature most people with light skin can stand it. And even that temperature will produce rosacea and will produce redness and dilation of the vessels with many people. So if you apply it, what happens? Within 2 minutes, the outer lid temperature goes right up from 37 body temperature, even a little bit lower than body temperature, 36. It goes up to 42. And that's enough to melt a lot of the seborrheic bleph, a lot of the debris, a lot of the desquamated epithelium, particularly if you follow it with the light scrub. But now let's take a look at what it does for the meibomian glands. Well, are the meibomian glands on the front of the lid or on the back of the lid? Well, the great maker, when he made the meibomian glands, thought of a child. And he thought of the putty. And he took the meibomian glands and he had the child press them right into the putty and then smooth it out. So the meibomian glands are only covered by several layers of cells. So when we have a warm compress, we have to drive the heat through the entire lid. And in a moment, I'll show you more information about that. So we started this long odyssey. The word odyssey meaning, just like in Greek mythology, a long, long trip. And we treated with heat and expression. And here's the slide that Tony showed. And in 1994, we published a paper that if we did manual expression once a month in the office, and the person used warm compresses, I think for 6 or 7 minutes, it wasn't quite up to 8 to 10, that they not only had a real increase in symptoms, improvement in symptoms, but they also had a thicker lipid layer. So getting the glands to work gave us a thicker lipid layer and reduced symptoms and made the eye feel better and act better. Well, that's a very good procedure. And I probably personally performed over 5,000 manual expressions. And I always wondered what happened to my patients. So I think out of the 5,000, I lost 4,900. They were just gone. So if anyone has a patient who is obnoxious, if anyone has a patient who doesn't understand and doesn't comply, if anyone has a patient who one thinks another doctor could do a better job for, what you should do is prescribe the full program. And the full program is to report back weekly for manual expression. And believe me, most of them will be gone. So, again, it took me the same 28 years to understand what pain is. So if you put on a topical anesthetic, it does not significantly reduce lid pain when you express. Now, there's several things that you're expressing. You're not only clearing out the obstruction, but there's undoubtedly a feedback loop system where when the gland is obstructed, and we have talked about this, and you taught me this many years ago, you would have a chalazion with every obstructed gland, unless what happened? The secretory process was down-regulated. Because otherwise, it would just keep making more and more sebum, more and more. It's a Holliker gland. It would make more and more cells. The whole process that Tony explained would go on, and the gland would blow up. And that doesn't happen. It happens, yes, some of the times. And that's the problem with people who have recurrent chalasia. The mechanism that shuts down the secretion when the gland is blocked undoubtedly isn't working properly. So what happens? In that gland, you have excess pressure. So it's the pressure on the walls of the gland that sends the message to the brain to shut down the system, stop secreting. And if that didn't happen, then everyone would have a chalazion, a non-infective increase in the size of the gland. So, in order to really effectively express, you need more than 10 psi. Now, psi, I'm sorry, that's pounds per square inch. And to put that in proper context, pounds per square inch, think of an automobile tire. And the pressure in an automobile tire is a lot of pressure. And it's between 28 and 30 generally. So you have to apply almost as much or more pressure on some of these glands than you would when an automobile tire has air in it, is applying on the wall. Tremendous amounts of pressure. So that's why, and we published all this information on several ways. And the topical anesthetic does very little for this. You actually either have to put a block in or inject portions of the lid with lidocaine. Now, if you think this is bad, there was a man named Addario who was in Italy, and in 1880, to clear up meibomitis, he developed a clamp. He went to the woodworking company who makes wooden clamps, and he made a miniature clamp, and he would put the miniature clamp on the lids, have the patient take several drinks of alcohol, and turn the screw until the gland drained. And that was the way he did it. I was unaware of that until I was standing lecturing, and a man kept raising his hand in the audience. He couldn't wait. He said, "Doctor," he said, "you're plagiarizing." I said, "I'm sorry, who am I plagiarizing?" He said, "Addario." And he knew all about Addario. And I said, "Well, how do you know about Addario?" And he said, "I did my PhD in the history of ocular treatment." And he's a very famous person in ocular treatment, and I would suggest, Dr. Korb, that you become more cultured. So I thanked him, and I went on with the lecture. So how has dry eye been treated in the past 20 years, 10 years? Well, we're focused on what? We're focused on water. So naturally, they developed drugs to increase tear production. And Restasis works wonderfully in dogs, and it works not as well in humans as in dogs, but it has been proven to increase lacrimal secrete. It has been proven to increase the production of the lacrimal glands, supposedly. And then you have punctal plugs again, and then you have eye drops, and lipids are better than anything else. And then we have warm compresses. Now, warm compresses, until something better comes along, will be one of the mainstays of dry eye treatment forever. It just has to be. And then we have lid hygiene and scrubs. And then you can use steroids, whether you give them topically or whether you give them systemically, and the same for antibiotics. And the question is, yes, they will do certain things. But no one has ever presented an adequate model or an adequate demonstration for any of these drugs dissolving the obstruction. So that would be ideal. And then we have supplements and omega-3s, and we were talking about that with various people here in Spain. And again, there's no clear data. Moisture glasses will become one of the standard methods. I predict that moisture glasses, as they get better, will become one of the standard methods for treating dry eye because it's extremely effective, because with high humidity, there's no evaporation. And with no evaporation, there's no desiccating stress. And then scleral contact lenses and other methods, including Lacrocert, and then manual expression. So we think about it, are these treatments palliative, just to make the patient feel better? Or are these patients really restorative? Do they really help? And probably the ones that are really restorative are warm compresses. So when we see and talk to a patient who has this, if you do warm compresses for 8 to 10 minutes a day, preferably twice a day in the beginning, and you really have wet heat, wet, not dry, is because if you can imagine, you're changing an electric light bulb, and the surface is dry, and then you're changing a light bulb, and there's water on the floor. You could get electrocuted. Why? Because water is a conductor. So when you use a wet compress, it conducts the heat. But then you have to keep the compress hot. So how do you keep the compress hot? Well, the best way to keep the compress hot was taught to me by a PhD in thermal dynamics from MIT, who, when I gave him my method, he came back, and he was very kind to me, but he was really telling me that I really wasn't very bright, which I know, so that was good. It reinforced my own thoughts. So what he did was, he takes just so you can understand, you take these towels and you roll them like that, one on top of the other. So you have 5 or 6 towels, all the same, face class. And when you roll them, you then put them in a microwave. And then when you take them out, the outer one, when it's the right temperature, you put it on your eyes. And when that gets cool, you flip it away and you take the second one and then the third one. Because the inner part is warmer than the outer part. So they stay warm almost indefinitely that way. So that's the way to use warm compresses, and it really is very, 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 very effective. And I would say that 75% of individuals we give it to say it's just the best. Now there's other methods too for doing it that we will get into. So warm compresses is really one of the great methods of managing all of this, and we have to express, and then I predict that humidifiers and moisture glasses will be great. And then if our problem is really desiccating stress, as I'll show you, then scleral contact lenses fitted properly will be great. But scleral contact lenses will not work unless the front surface is lubricated. And what controls the front surface lubrication is the oil from the meibomian glands. So if we have meibomian gland dysfunction, meaning not much oil, it's almost impossible to wear scleral contact lenses well. Thank you very much. It's almost impossible to wear scleral contact lenses really well because you will develop GPC and lid wiper epitheliopathy because there's no lubrication as the lid comes down. And a good way to think of blinking is to remember that the number of blinks per hour when you're blinking is about the same blows that the feet have in walking a mile. So your left heel or your right heel touches the ground and has impact 1,500 times per mile. And that's about how many times the upper lid has the same problem. So it's very, very, very important that it's lubricated, because if it isn't lubricated, the individual will not blink. And if the individual doesn't blink, my new favorite word is cascade, because everything starts a cascade. And if you don't blink, the cascade starts. The meibomian glands become dry. The surface of the eye doesn't get wet. I mean, just like in paralytic facial palsy, for instance. If you don't blink, you have Bell's phenomenon, Bell's palsy, you don't blink. It's very, very dangerous because over a period of time, as you cornea people will tell me, you could develop very serious complications, even leading to tarsography. So that's the way, at least as an introduction, to think of some of that. And then, so all this went on without much success, because I jumped ahead and I added some of the more modern techniques to it, but it didn't really have a lot of effect. And then in 2011, from the heavens came this meeting, and the meeting ended up with meibomian gland dysfunction, MGD, may well be the leading cause of dry eye disease throughout the world. Okay? And that was 60 people who spent 2.5 years on that. Not one of them, I don't believe, emotionally liked what they found or what they said. But that's what the data said, and that's what the final report said. And they defined meibomian gland dysfunction as a little bit different than we did. They added the word chronic, which is great. It is obviously a chronic disease. They didn't put in the word progressive, which should be there. If I were to define it, I'd say it's a chronic progressive disease, as I'll show you. And they had what we had, Dr. Henríquez, terminal duct obstruction. And then they said what this may result in. So it may result in all these different symptoms. And my comment is that sequelae can be very severe. And again, the term dysfunction doesn't mean infection. It doesn't mean inflammation. It means no sebum. That's what dysfunction should mean. And that's the way we defined it. So now we want to know, how do we diagnose MGD? Well, it's important because we now know that 86% of all individuals presenting with dry eyes either have severe MGD, where that's the prime cause, and the eye is not aqueous deficient, although, as I will explain, I don't believe that's true, or perhaps 30% of all individuals have both aqueous deficiency, as defined by a Schirmer test, and meibomian gland dysfunction, as defined by lack of sebum. Now, just to chat for a second and digress for a second, what happens is that if you don't have enough lipid layer and you have desiccating stress, everything has to upregulate. So the lacrimal gland has to upregulate and make more tears. So if we test them at that time, we get a high Schirmer, and we believe that we don't have aqueous deficiency. But then the lacrimal gland has been running a marathon. And what happens when you run a marathon? The same thing that happens to the onslaught of type 2 diabetics in the United States at 35 years of age. They batter the Isles of Langerhans. They batter the pancreas with what? All this sugary junk. And in my opinion, it isn't really insulin resistance the way it's classically thought of, but we just wear the gland out. It just can't do it. It just can't do the job. It's not made to handle that bulk for more people. Sure, some people can do it, but some people can't. But the majority of people can't do it, and we have this massive epidemic of type 2 diabetes. So that's why it's important. And now if we think about it, it's this simple. With meibomian glands, which is at least 60% of all dry eye, it's function and structure. So we got to get better function, but we can't get better function if we don't have structure. So let me go through this in a logical manner. So in order to understand function, you have to have a metric. And if I use my finger on the glands like I used to, and in this photo it shows that's my thumb pressing against the lid. If we do that, it's an art form because we press differently than other people press. So we have to really know what we're looking for. So what we did is we built an instrument that standardizes this, and what it does is it applies 1.25 grams per square millimeter, and that number is not important, except that that's exactly the amount of force the muscle of rhyolin places upon the meibomian glands in a normal blink. So we can now test to see, with a standardized test, to see if the meibomian glands are functional. Just place the patient's head in, you bring that up against them, you press, and you look to see if there's sebum coming out of the orifice or if there's no sebum. And what did we learn? Now, all of this work is published in good journals, mainly in cornea. What we learned is, believe it or not, the nasal glands produce 65 to 70% of all of the sebum. The temporal glands produce less than 5%. And the central glands produce the balance, 30%. So what that means is, for years when we look at it and we press, we usually press, because we're coming temporally, we press more on the temporal glands than we press on the nasal glands. And in order to press, you have to be normal to the surface. You can't be tangential. You can't be oblique. So it's a lot of technique, which is quickly learned. So it would take a normal person about 1 minute and 30 seconds to do both lids. And the next thing that we learned was if in the lower lid you have less than 4 glands, there's a 90% chance you'll have dry eye symptoms. And we learned that if you have more than 10, there's less than a 10% chance that you'll have dry eye symptoms. Now, of course, if you're an airplane pilot and you fly a plane in 0 humidity, this will be a little bit what. But we're talking about the normal people who work in an office in the average situation. And then what we learned is that with contact lens wearers, contact lens success is correlated to the number of glands. And that's where Tony and I started. Because the patients we made this discovery on, a lot of them were keratoconic patients. And these keratoconic patients looked great, but they couldn't wear their contact lenses, and they had all these dry eye symptoms. And then, as I just said earlier, that's a very important instrument. Now, over here, we have a dental x-ray. If you went to a dentist, and the dentist said, you don't have to floss, you don't have to brush, I have a solution which you'll gargle for 30 seconds once a week, and everything will be perfect. How many people in the room would stay with that dentist rather than leave them? No, no good. You'd leave the dentist. We have Dr. Henríquez who affirms what I said, and he says he would leave that dentist. Thank you. But that's what we're doing with eye care. That's just what we're doing with eye care. When was the last time you took an x-ray of the meibomian gland? Anybody in the room ever taken an x-ray of the meibomian gland? You have taken it. And do you find anything? You find a lot, for sure. So, wow. So what's happened? Did somebody said wow? Oh, you did. Okay. So there's a lot of different methods, and I won't go into it, but we have developed a better method of doing it where it's much clearer. And here, on a standard one, we can actually see the acini. We can begin to see the blockage. But this is just, even the best is just generation 2. And it's called Liposcan, and I'm one of the inventors of it, just to make the statement. And it combines both infrared reflective technology and transillumination simultaneously, and it balances to see which one is giving bad data and which one is giving good data. So here's your glands, here's your acini, here's the spaces. And here's moderate loss, and here's severe loss. And here all you have is stubs. You have no acini left. So the gland is not capable. And I would say today my practice is probably 80% or more just dry eye. And I see people from all over. And I would say that I see that out of 25 patients 3 or 4 times a day. And when we go in and we look at students in a study that is now submitted for publication, and some of you might be the referees on it, when we look at students, first-year students in dental schools, medical schools, and optometry schools, 50% of them have that amount of loss or more already. So we're breeding a generation that 50%, Tony, yeah. Now, what does meibomian glands have to do with glaucoma? A lot. Because glaucoma and the drugs help make MGD. But it has something even more important to do about glaucoma. And we have a glaucoma specialist, thank goodness. If I were to say to you, we have a good-looking cup, okay? You would want to see that patient as a routine patient, 1 year, 2 years, 3 years, whatever you decided in your professional judgment said was good. Now let's suppose that over the course of 10 years, that the cup went from there to there. Would you send them away for 2 or 3 years, or would you do a lot more tests? You'd be concerned now. You'd be very concerned. And now, if you saw that, and there's almost no pink rim left, just a little bit, you got a 0.8, 0.9 cup, Would you not treat them? Would you send them away and say, use artificial tears? No. Anyone who did that would be guilty of what? Malpractice. I mean, it's preposterous to think that way. And yet, that's what we do now with dry eye and Meibomian glands. We give them tears, we give them whatever we have, and we send them away. So, am I being provocative? Yes. Am I being truthful? Yes. Do I believe this will happen? Yes. Do we have the evidence to show that it will happen? Yes. And it's very sobering because man has created a society that's causing this. We're not made to do this. Our bodies are not made, our bodies just aren't made to sit and look at screens, you know? Our bodies are made to look at what's in our hands and not for prolonged periods of time. And we're not designed to stare. So when we go on a computer screen and we anticipate what's happening, what happens to us? We stare. And if you time, and the literature, there's 50 papers on this, the mean blink rate changes from the mean blink rate changes from anywhere from 7 to 10 seconds, which is about the normal, to as much as 30 to 60 seconds on a computer. But if you ask the person to look at you and stare, they can't do it. So if I ask everyone in the audience now to understand staring and what it does, and you just look at me, and what we'll do is we'll say blink 1, and then we'll say stare 1, stare 2, stare 3. Okay, blink once, blink please. Now stare 1, stare 2, stare 3, stare 4, stare 5, stare 6, stare 7, stare 8, stare 9, stare 10. How many people had to blink? Okay. And what was the sensation? 75%. And what was the sensation? And don't be afraid. What did you feel?
Burning.
Burning, right, burning. And why? Because it's desiccation. So if you put someone on the computer, that's what happens to them. But they don't feel the burning because the neural mechanism for survival stops them from doing that. It provides cortical anesthesia. It suppresses the impulse. Now, when Spain was a great sailing power in the 1500s, they had